management and clinical function actually going into not only the physicians, but provider systems, which may be your integrated delivery networks in hospitals. So that's happening as we speak. In terms of tort reform, I mean, this is something that Rich and I have had a conversation about in the past many times. It's going to have to be led in the state. Because if we look for federal tort reform, the opportunity was there during the Affordable Care Act, but all we got was a few opportunities to do demonstration pilots or programs around it. Can we scale that? Absolutely. But when physicians leave New Jersey and they're going to states where the tort reform is there and the environmental practice is more amenable to them, you see them succeeding there. So it's going to be all of us working together to see how we can truly bring about tort reform in the state. And I know, there are lots of people in the administration and in the legislature that see this as an issue.
I'm sorry. In our more data-driven health environment, there's now, I think, a movement in the courts themselves, without antitrust law even, to give physicians the benefit of the doubt when they follow the best practices. So as best practices become more widely known and so forth, and of course there's efforts on Capitol Hill to create a safe harbor for those who do follow best practices.
Just on the administrative hassles for physicians' offices, when I talk to doctors' groups, as a payer, we often hear this, and I think it's an inconvenient and troublesome aspect of our healthcare system. The challenging part is that it does, in many ways, control costs. I mean, I'm just giving you an example. One of the plans that we work with, we're meeting with a physician group, and we're going over the cardiology case where they said, authorization is being provided 99.7% of the time. Why are we going through this? Let's lift the authorization process. What had happened is that they tracked the utilization after they lifted, sort of gold-plated or gold-carded a certain segment of the cardiologists who were always getting these high rates. And what happened is the utilization spiked very quickly, and which had been pretty steady. And the health plans would point to the sentinel effect of knowing that there's some possible review on the back end does have a change in behavior in physician prescribing practices. The other thing I'll point to is that when there are appeals to the state, so health plans ultimately, if they say, well, we deny the service, we don't think it's medically necessary, we're not covered for the service, there's an appeal right under federal and state law. When you look at those, the appeal to the health plan, and then it goes to an independent group, the Independent Utilization Review Organization, completely disconnected from the health plan. When an independent reviewer reviews those cases where physicians have gone to the mat, on average, health plans win those appeals with independent orders 65 to 70% of the time. So it's I think health plans would love to get rid of utilization review and sort of those headaches. And there needs to be a better job about the communication, and it doesn't always work well. The challenge is that there is inappropriate utilization that happens, and that's why kind of those reviews work. But I would certainly agree with your point that it's time consuming and costly to the physician, and we need to, payers and providers need to work better together at delivering care so that so much time isn't spent on that.
Kuna made an interesting and important comment related to medical liability reform. No, but one that I'm going to add to, and that was the comment that you made about the relative position of the states, whereas some states have improved their medical liability civil justice environment, that then makes New Jersey relatively less attractive as a place to practice medicine because of the harassing nature of the civil justice system. There's the other side of the coin aspect of that's also important, that as other states improve their medical liability laws and civil justice laws, if New Jersey gets relatively worse in the ranking, more lawsuits get filed here. Because you can, in many cases, under the venue, choose where the suit is going to be filed. So if other states get better, then New Jersey attracts more litigation. And this is something that is a matter that the legislature can't act on. Some of the adverse elements of New Jersey's medical liability have been established by the courts, and are areas where the legislature can be free by statute to improve the environment.
I was just wondering, health savings accounts, have they proven to be a viable option to traditional health insurance? And also, why do you think the idea of purchasing insurance across state lines hasn't really picked up steam?
Okay, I'll take a crack. I'll go reverse order there. Across state lines, I know that frequently gets discussed. I don't want to speak for my organization right now, if I could, but it's just, I think the challenge is that when you offer coverage across state lines, the question is what rules apply. So a lot of what determines price and product in New Jersey is the regulatory plan. It's what does the plan have to offer. So if you could have a state from, if you could offer Missourian coverage in New Jersey, but it didn't have to have those 35 mandates, and you could rate based on, age and gender in a different way. If you have sort of a different regulatory climate, you could run the potential of someone, an entity sort of picking the better risk folks and cover them at a lower rate, and push off higher rates to the folks that remain. So it's a challenge. I mean, competition is good, but I think you have to do it in a way that you ensure that folks are competing on a level playing field. If you don't, you run the risk of just sort of segmenting risk and sort of giving low risk folks to some health plans and higher risk folks to other health plans. So if it can be done around sort of equality around the regulatory climate, that's okay. On HSAs and health savings account and those mechanisms, I think they have been successful in large measure. We are getting to a point where consumers are better judging and evaluating how they, when they have skin in the game, they behave differently. There's no question about that. I think it's been successful. Some of the challenges have always been around folks with chronic conditions who need medications, and if you do have a chronic condition, you'll probably have to utilize benefits in a different way. So I do think it has had a benefit. We've seen an increase in the number of HSAs across the country. And as pricing transparency and quality transparency becomes a larger portion, more prevalent, I think that they will, those HSAs will be sort of better served by that transparency.
And I think a lot of the employers are actually going in that direction. They're going to be offering it, especially the large employers. And in fact, when you looked at the Affordable Care Act, one of the perspectives that the Republicans had, which was the HSAs being sort of a solution, where the member or the patient is able to manage their own healthcare dollars with incentives built in and accountability. So I think it's going to evolve very rapidly. The HSAs first came out in the early 2000s. It was somewhat of a hiatus after that, but now you're going to see it actually growing really, monumentally in terms of the uptake and the adoption.
Only about 2% of employers offered HSAs in 2002. It's up to 70% this year.
Yeah, that's what I'm saying. So it's amazing how it's growing.
Why did they lower the amount that you can deduct into those accounts? It was $7,500, now it's $4,500. Why did they give that deduction when they were not moving the pocket?
You mean under the ICA?
Yeah.
Well, the small group deductible limit, the administration's already basically waived that from a regulatory standpoint, and we now see a move afoot in Congress, bipartisan, to strike it out of the bill.
Could we come back to the concept of medical necessity review and tie it into what Rich Baker was talking about, patient access to medical innovation? And there are a lot of plans which will say, oh, you have a condition which can be treated, but there's a cheaper way to do it rather than first line product. Can you just talk about that conflict?
Yeah, I don't, the medical necessity review takes different forms, but it's, on prescription drugs, for example, there's a huge, distinction between the cost of generics and brand name drugs. And there's no question that there's an incentive to try to steer folks to generics. New Jersey has a law that, related to that, as a matter of fact, so that unless the doc says dispense is written, it can be dispensed as generic. So the medical necessity review, New Jersey has a pretty strict regulatory climate around that. It's different than most states. Most states allow what's called a closed formulary, where they can keep certain drugs off of the formulary. The Department of Banking and Insurance does not allow that. So all drugs have to be on the carrier's formulary. They may have different tiers in the drugs when it comes to cost sharing to identify that. So, in terms of medical necessity review, I think that there is some evaluation, a little off my comfort zone here, but I think that there is some evaluation that's sometimes done around the efficacy of drugs. They'll try to steer you to one drug first, if they do a step therapy, where they would, or fail first protocols, or say, this drug is therapeutically similar or the same, and we're going to ask you to try this first before you go to this drug, because the cost delta is really significant. Without those in place, and you could have that, I would anticipate the cost would be significantly higher on the premium side.
I think one of the observations that I have as a physician is that, yes, there's the appeal process, but it's time-consuming, it's onerous. Could there be ways of streamlining where the process could be simplified? Or if, say, medication is going to be reviewed annually, why couldn't it be a simple process of Mr. X continue to take this medication? Does this medication continue to be appropriate? Do you want to continue it for another year? Something that would be much more efficient. It strikes me that the process is made deliberately onerous to basically prevent physicians from taking that time. I know physicians who will not appeal any medication. That if it's denied and the person is stuck, they have to pay out of pocket, which is a very punitive approach. So why doesn't the industry simplify it so that it's favorable still to the industry, but also favorable to patients and physicians?
Well, I mean, does the process work smoothly all the time? And I guess the answer is there's always an opportunity for improvement in how this process works. There's different payers. One of the challenges that you sometimes have as a physician is that you'll see a patient and they will have switched health plans.
Right.
So you start to go through your process and you ask yourself, well, we tried this drug and why? So I think that those transition to coverage is a lot of times where you'll see that. Not quite sure what the solution for that is. You certainly see, especially with smaller employers, surfing based on price. So they'll, one year they'll be with, Horizon, the next year they'll be with Cigna and Aetna, and they're surfing the cost. I don't dispute your point that the process sometimes is rocky. There's probably some room for improvement there. But I will say that the cost differential is really significant on some of this stuff. So the difference between a generic and, a brand name can be extraordinary. So, health plans have undertaken these steps, with that, one of the biggest concerns they hear is on the premium side from the purchaser saying it's extraordinarily expensive. And I will say, just to go to the point that Dr. Lay made on different evolving models, one of the interesting things that's happened as it moves to ACOs, where docs and other providers are taking on some level of risk, is you've started to see the activities of payers and docs start to look like they're very similar. So I've seen ACO models where they're instituting sort of fail first or step therapy kind of processes because they're at risk on the financial side. And I've seen the financial. Can it work better? Yes. The answer is yes.
I'm going to add a comment. It's a really basic one, but I think it's a comment that's always worth making when discussing drug substitution. And that is we're talking about two very different categories of substitution, right? New Jersey, like virtually all the states has a generic substitution law, whereby unless the physician specifies on the prescription dispenses with or do not substitute, the pharmacist makes an exchange at the pharmacy to a generic formulation of the same molecular entity that is determined by the FDA to be equivalent and is manufactured by the generic company within standards of equivalency. That's generic substitution that happens in the vast majority of cases, except in those circumstances where the physician's judgment there should be a substitution. There's also, and sort of wider discussion of these issues, these two get overlap sometime. There's substitution of a different molecular entity that has not been determined and nor has been ever claimed to be the same compound, but based upon a sort of restriction in what's available through a formulary, and then there's a back and forth between the prescribing physician whose judgment is as to which is the best therapy, and the plan in terms of what they pay for. So there's two elements of it. Yes, there's a generic form of an off-patent product, right? The price reduces dramatically, but substituting from a single-source product to a multi-source generic is a therapeutic decision that's sometimes appropriate and sometimes may not be appropriate, but that's where the physician's judgment is crucial.
Thank you for clarifying that, because it was really the second class that I'm addressing, where they want you to really switch to a different medication because that one was less expensive, usually at the detriment of your treatment. And I'm not denying that sometimes a certain brand of medication is more expensive. Absolutely, that happens. But sometimes that more expensive medication is being quite effective. And you also make an excellent point that often is when someone switches companies where the prior company was paying for it. They've been now maintained on it, not just for a few months, maybe for years. I happen to be a psychiatrist. So, that I'm sometimes placed in situations where I'm being pressured to change to medication that when the person switches, they may end up in the hospital, they may end up being suicidal. There is a significant human cost to what is being forced on these individuals in a cost-saving way.
Yeah, the other sort of thing that makes this also sort of bumpy ride is that on you have the switching from carrier to carrier. You also have a fairly regulated marketplace in New Jersey around the insurance market. You also have folks changing jobs where they go to a large employer, self-funded, and then it's a completely different regulatory climate where the state doesn't have any regulatory authority over the self-funded plans. So sort of the balkanization of how coverage is provided, it's no one designed the healthcare system we have, but it is the one we have. That's, in that kind of substitution issue, it does become particularly challenging if folks change jobs or the employer changes the source of where they get their coverage.
And electronic medical records will help that.
And also, I think just the one other thing that I know Rich is familiar with in his company is that the comparative effectiveness models that are coming out of the Affordable Care Act. So looking at what the current therapeutic regimen is, and then how does the new treatment compare to that? It obviously doesn't, involve the boutique drugs or those really, very high cost or special kinds of or oncology type diagnoses. But there are provisions now around comparative effectiveness that are going to come to.
And this is an area where sort of the policy environment and the science are diverging, right? Because the science is headed more and more to precision medicine based upon your personal genome that will determine that a particular treatment works for you and we'll know why. That's the future. And a different therapeutic option will work for the next patient based on very personalized reason. And so the idea of comparative effectiveness on